something that we can sort of think about for the next
off. Well, yeah, thank you very much for inviting me to talk, and thanks for everybody coming along and listening to the webinar. So I am going to sort of talk a bit about hearing loss and dementia and some clinical considerations. So I work in the Manchester Centre for Audiology and Deafness as a research fellow, but I'm not actually an audiologist myself. So my background's in neuroscience and in clinical neurology, neuropsychology. So that's really where my interest, sort of my training was in dementia care and looking at patients, and really my research interests were looking at the links between hearing loss and dementia. So I'm just to sort of make sure that everybody is on the same page when we're talking about dementia friendly and adapting practice. I'm going to give a bit of background on dementia and cognitive impairment. I always start like this. Just so I apologise if you've heard this all before, or if anybody already knows this, but talking to a group of audiologists, just want to make sure that sort of everybody's on the same page for when we're going forward. So, can't move the slide on. So dementia is a group of syndromes which is used to describe a progressive decline in more than one cognitive domain affecting activities of daily living and independent functioning. So when we think about dementia, we don't necessarily think about this definition, and it's really, I think it's really hard for people to sort of, what is dementia? And everybody has their idea of what they think it is, but really it's not associated with any disease. So it's not memory loss. It's not, people, sort of at the end of their life not being able to dress themselves. It describes this collection of diseases which cause these symptoms. So Alzheimer's disease is the most common cause for dementia because it results in a progressive decline in more than one cognitive domain. So the main cognitive domain associated with that is memory loss, which is why we tend to sort of think dementia and memory loss are synonymous, but they're not necessarily. And it leads to this progressive decline, and unfortunately people end up not being able to undertake activities of daily living and independent functioning and require support and care for things. So when we talk about the symptoms of dementia, they are very varied, and they depend on where the disease is in the brain and what sort of disease it is actually affecting. So Alzheimer's disease, as we've said, tends to, the earliest and the most prominent features are memory loss, but there's also sort of widespread cognitive declines, and we see that in things like decision making, orientation, reasoning, problem solving, language. All these different cognitive domains can be affected, and they'll be affected in different ways. So unfortunately, we don't have any cure for dementia, for many of the causes of dementia. We just have symptomatic treatments. And because of this, it's one of the leading causes of disability in older age, and it's been recognised as a world public health priority. And this is, as our population is getting older across the world, more and more cases of people are living with dementia. And this is the same potentially for the number of people coming in and visiting the audiology clinics. So I wanted to kind of try and make this distinction early on, because I think it's really, I find it really sort of useful for helping to guide the discussions. That cognitive impairment and cognitive decline, again, are, slightly different aspects. You can see on this graph here, the top line is the sort of the purple or the black line is normal cognitive decline, and this is what we would expect. So we would expect people as they get older to become a bit more forgetful, to become a bit slower at processing things, to not be as quick at problem solving, and that's absolutely normal. And I guess that's something that you probably come across a lot in the audiology clinic when you're seeing older adults with hearing impairment. People might not be as quick to pick up new things as potentially younger people. But when we're talking about cognitive impairment, rather than a decline in kind of cognitive abilities and dementia, we're really talking about something very different from normal age-related declines. So this is the what we sort of term pathological aging, and you can see this green line. There's a sort of a steep. It runs very closely to the normal aging trajectory, and then we have a bit of a steep decline, and over time it sort of gets steeper and keeps declining. And you can see that actually when this decline has started, it is very different to the normal aging trajectory that we would expect. And this is kind of what we're going to focus on for the rest of the talk. And when we're thinking about clinical considerations, it's really how do we help these people with this abnormal cognitive impairment. So where does hearing loss come into this? And I'm sure everybody will have seen that there's appears to be, or the research studies have shown us, that there's an increased risk of developing dementia for people with hearing loss. And this is also dependent on the severity of hearing loss. So the more severe somebody's hearing loss, the more likely they are to develop dementia. Also, this trajectory of cognitive impairment is accelerated for people with hearing loss. So if I go back to this slide before, when we see how sort of there's like a rapid decline, a gradual decline for normal and a bit more of a rapid for pathological. For people with hearing loss on the normal or pathological, there tends to be a much quicker decline. And then also, since 2017, we've had hearing loss included as a potentially modifiable risk factor for developing cognitive impairment and dementia. So this is really saying that if we could get rid of cases of hearing loss, we could potentially get rid of 9% of the risk of developing dementia, which, you know, is fantastic, and it's, you know, higher than hypertension, obesity, smoking, depression. So really putting hearing loss on the market for a really important factor when we're talking about cognitive impairment and dementia. But we don't actually have the evidence that getting, you know, how do we get rid of hearing loss? We don't, and what we do is we treat hearing loss with hearing aids, but again, we're treating the symptoms of hearing loss. We're not actually stopping the hearing loss happening. So we don't actually know whether treating hearing loss or treating the symptoms of hearing loss does affect this risk. And there's lots of studies going on to try and answer this question, but it's really, really tough because of the ethical implications, and really what we'd have to do is give some people hearing aids, give some people cochlear implants, give some people, you know, any other kind of how do we modify this hearing status, and we follow them up over time. And obviously that's unethical if we think that we could reduce the risk of dementia withholding treatment which is readily available on the NHS. We wouldn't be able to do that in this country. So there's still, and this is why I like to sort of bold this potentially modifiable risk factor, because we're not 100% sure whether we can actually say that with the current evidence that we've got. But saying that is not the whole picture when it comes to cognitive impairment and dementia, and sensory impairments and hearing loss. You know, there is a much bigger picture, and hearing loss actually represents an unmet need when we're talking about people with dementia. So if you have dementia plus sensory impairments compared to somebody who just has dementia and has normal hearing and vision function, we see that people who have got the hearing loss have decreased rates of sort of of orientation and knowing where they are in time and space. They have decreased rates of social activities and hobbies, and decreased community and social interactions. They have increased hallucinations, delusions, depression, aggression, and all the kind of behavioural and psychological features associated with dementia cases. They also have increased isolation. From family carers report that there's increased and accelerated burnout, and the whole sort of situation is more distressing for the person with dementia and their families. And this leads to agitation and really poor quality of life. So we can see that actually, if we even sort of ignore the risk factor, when we actually take somebody with cognitive impairment and dementia, if they have hearing loss, they're more likely to have negative impact on mental health and cognitive well-being. So really we we really have a duty to be able to support, and this is sort of as audiologists, to be able to best support these patients as best we can. So it's not as sort of straightforward as that, though, because hearing loss in the dementia population is really, really poorly recognised. So this was a study done a fair few years ago where they took people living with dementia and they measured their hearing, and they saw that 80% of them had a previously undiagnosed hearing loss. And this is similar across various different studies who've done similar things. And only 7% of this population actually had been given or were using hearing aids at the time. And this might be because people living with dementia, and depending on where they are, might not be able to verbalise their hearing difficulties. And when I say where they are, it's because we sort of refer to dementia being a journey, so where they are on this trajectory that they have, because we need to bear in mind that it's not going to be the same for any two people, because everybody's brain and everybody's cognitive abilities are very different, and depending on exactly where the disease is in the brain will lead to the different symptoms, and it will lead to a different progression of symptoms and cognitive impairment for that person. So people with dementia, if they can't struggle to hear, they might not be able to pin it down to not being able to hear because they've got problems with auditory processing. So that, this is a challenge in itself that we potentially need to try and address. There's also that the early symptoms of cognitive impairment are very similar to those with hearing loss. So carers, family members, and professionals themselves who are sort of looking at cognitive problems might misattribute some of these symptoms and lump them all as, oh, this is all due to the dementia, when actually some of these, such as difficulty following conversation, question repetition, decreased understanding when you're talking to them, these could be due to that they're not hearing very well, not necessarily to do with the fact that they have got a cognitive problem. Further to this, hearing loss can complicate dementia assessment. So there's been many studies which have shown that if you simulate hearing impairment, people perform poorer on cognitive tasks. And this was a study done with using the mini mental state examination, which is the most widely used cognitive screening tool, and showed that these were young, healthy adults with no cognitive impairment and no hearing impairment. And when they had a simulated hearing level, which was sort of mild to severe, if we look in the middle of the graph, we can see that people reported to having a really low score of under 20 on the MMSE, which is suggestive of moderate cognitive impairment, and really, they have got dementia. So again, it kind of muddies this picture. Are we overestimating cognitive impairment in some cases, and in some research studies which are potentially not doing a full history, but they're only looking at cognitive scores, and it's really a lot more so I think needs to be understood from both a cognitive, the memory clinic, the memory clinicians, and the hearing professionals. They all need to sort of try and understand what's going on in each other's fields. So this is something that we really got interested in when we're looking at the links between these risks, and sort of saying, well, if people perform worse on the tasks, does it mean they've got dementia, or does it mean that we're just not measuring it very well? And we did a study a couple of years ago where we really wanted to understand clinicians' perspectives on this. So we asked hearing professionals, vision professionals, and dementia professionals, and also general GPs, how did they feel about all these different things? And we asked sort of hearing loss in respect with dementia in respect with hearing and vision separately. And what we wanted to know was sort of, what do you understand about it? Do you ask about these questions? Do you use them to guide your practice? And we also held some expert reference groups to really get grips of what clinicians were saying. But I've just put one of the results here, which was from this survey we did, which showed that there was actually 99% of hearing professionals from the UK who responded to this survey said that they would find guidance regarding, cognitive impairment and dementia, what we can do for our patients, what does it mean if they've got it, they would find it really useful. So from that, for the past 2.5 years, that's sort of what I've been working on with a team of people at ManCAD, but also internationally. So and across the UK and across the world. We're sort of this is not something that is is just UK wide. Hearing and dementia professionals don't really interact much in clinical practice as much as people would potentially want them to be. So multidisciplinary guidance is needed, and also I think more guidance, specific disciplinary guidance is needed with input from the other domain. So this is what we've tried to do, and we have created 2 sets of recommendations. Now, with everything, these take so much longer than you plan them to be. We were hoping these were going to be out last year, but they will definitely, hopefully, be out this year. So we've submitted the international clinical practice recommendations. So these are the recognition and management of hearing, vision and cognitive impairment. So these are more general. And then we've also looked specifically for the audiology profession, looking at hearing assessment and rehabilitation for adults living with dementia. And we've written this as a really multidisciplinary team, because I think when we're trying to understand the complexities of working with adults living with dementia, we can't just leave it to audiologists on their own to be able to sort of trial and error things. We really need input from dementia professionals, from care professionals, from occupational therapists, and the audiology profession. So that's what we've done for this second paper. In the first one, we have a mix of hearing, vision, cognitive impairment and rehabilitation therapists in there as well. So the first one, which I'm not going to cover too much on, but it's really, I think these documents, when they're out, will be really useful to use in tandem. These ones have got to be relevant to all 3 domains. So there isn't any specific guidance addressed at audiologists in terms of adapting your practice for sort of evaluation and management. They're more broad strokes, and there are some little tips in how you can take into account vision and cognitive impairment when you're thinking about your clinics. But what we really found from this work is that there's no point in us kind of saying this is what people should be doing if awareness and knowledge is low. We don't know how to detect these themselves. The support isn't in place when people have got a diagnosis potentially of combined hearing and vision, hearing and cognitive impairment, and the services and policies aren't there. And so this is what we've tried to do is really have recommendations to increase awareness and knowledge of professionals, but also the general population. And then there's the sort of evaluation and management are really what we've picked out, a little bit about policies as well in this second manuscript, which I'm going to kind of talk through some of the bits of that now, which are really kind of relevant to audiologists, I think, in terms of understanding. And I think I saw somewhere was written kind of things you should consider before, during, and after the assessment. And I think it's really important to consider that these are a group of patients particularly that need a bit more thought and planning in setting up a clinic, if that's what's happening, or inviting them to an already running clinic. So we understand that people with cognitive impairment have particular needs, and this is people with cognitive impairment have told us this. And this is in terms of dementia-friendly clinical settings, not just for audiology, but for all clinical settings. And also, audiological assessments and rehabilitation strategies need to be tailored to support individual requirements. And these depend obviously on people's audiometric hearing levels, how we're going to be able to offer them rehabilitation, but also the impact of cognitive impairment on this, but much broader in terms of the social context, their personality, their background, other health factors, what's their goals, what do they want to get out of it. And I think this is what we really need to focus on when we're thinking about setting up these clinics for people with cognitive impairment is there is not going to be a one size fits all. So there is going to be some trial and error, and it's going to have to require a really flexible a sort of assessment and setup process, which I guess is quite hard to do. You know, I don't, as I've said, don't work as a clinician, but you know, there are, you know, certain constraints that you have to do within your clinical practice. So sort of saying, well, we're going to throw that into the wind and you've really got to, you know, just take this person as they come, can be really challenging. So we want to set out some tools and some guidance to be able to help based on the evidence we've got in the literature, but also based on our sort of clinical view from this multidisciplinary groups of people. So this was something that potentially we could look at when we're thinking about working with people living with dementia. So this is something you could consider before the clinic. So if you want to be able to invite people with dementia, you really need to understand the nuances of being able to work with this particular population. And as far as I'm aware, across the world, audiologists typically receive very little training when it comes to cognitive impairment and dementia, and that's exactly the same for people when they're looking at memory loss and dementia and neurodegenerative diseases. They don't typically look at hearing loss either. So what we propose, sort of trying to produce to audiology, is this VIPS model, which was proposed by Brooker and Latham in 2016. And this is sort of some basic principles that you need to understand when working with people living with dementia. So we've got valuing the person with dementia. I is the individuality. P is looking from the perspective of the person. And I think this is something that when I am sort of trying to put ideas forward for adapting audiology practices, this is the one that I think is really quite easy to visualize. And you think, oh, right, okay, that makes sense. This is why we need to change or we need to adapt our practice. And looking at the social environment. So this is a table I've sort of I've taken from our manuscript, adapted it and blown it up a little bit. And using this VIPS, we've tried to kind of put what does this mean for audiology, and if audiologists are going to use this, how can we, you know, use this VIPS principles to be able to guide our practice. So, you know, valuing people with dementia and those who care for them. This is really, really important, and it's ensuring there's fair access to audiology services to meet the needs, regardless of the level of cognitive impairment. So, and I'm sure your audiology practices would be, you know, you wouldn't not see somebody if they had, you know, a more severe cognitive impairment. But you need to be able to have the training and the awareness to give positive value then to people coming in. And I think this is something that is still really, really in its infancy, is, you know, what are the best ways to be able to support people? And it does start with staff training and staff awareness of understanding the very basic complex needs of people living with cognitive impairment. And then from this, sort of staff should feel supported to be able to make positive changes to their practice to meet the needs of people with dementia. And by understanding this kind of training and awareness and this access to audiology services, it is really trying to kind of get to grips of, we know people with cognitive impairment will have progressive declines, they will have fluctuating cognitive capacity, but somebody who has a diagnosis of Alzheimer's disease, for example, will have very, very different they will present themselves very differently at the audiology clinic to somebody who has frontotemporal dementia. So if we sort of have a dementia clinic and we say this is the one test we're going to use, that's not going to work either. So really kind of some more in-depth training is needed to understand the complexities. Moving on to the individuality, that's kind of, you know, basically it's intertwined in all of these. Practices need to be flexible, and it's okay to ask people how they are, and to have a bit of a chat and trying to glean what that person wants from their audiology appointment, and relying on, or using, maybe not relying on, but using family members and significant others if they're there. And this is something that, again, we don't want to lump everybody. If they have a diagnosis of dementia, they might live very independently for a number of years. They might not have a carer. They might come on their own. And that's, that is something as well we need to think. It's not all, oh my gosh, somebody's got dementia, we can't do this assessment, or they're not going to be able to tolerate hearing aids, they're not going to tolerate their appointment. It really does need to be flexible. Looking from the perspective of the person with dementia, and I think really this is kind of understanding the physical environment and how it might be perceived with somebody, because as we've said, it's not just memory that's affected, and quite often, and especially as dementia progresses in many people, we see problems with spatial orientation, with contrast, so really, the physical environment is very important, but also just the coming to the clinic and having a hearing assessment, that might be really quite confusing and frightening for somebody if they don't really understand what they're doing or why they're there. And it is a bit, I guess it is a bit daunting being told to sit in a booth and click when you hear the tones, if that's something you don't really do in your everyday life. So it can be a bit confusing, which can lead to other issues. And then obviously we've got kind of trying to create this social environment that supports relationships and interactions that promote well-being. And I think audiology is really well placed for this, because by improving somebody's access to sound, we're hopefully going to improve their social relationships and interactions. But it's also thinking about the audiologist's interactions with the people with dementia as well. So sorry, it's a bit of a whistle-stop tour through that. Something else to consider before bringing people into clinic is potentially looking at our appointment letters. So they have to be clearly written. And I know people will say, well, with these are standardized appointments, but they have to really, if they're going to be accessible for people with dementia, we potentially need a dementia-friendly appointment letter, bearing in mind that some people will have carers who might take care of their appointments from them, and some people might not. And we need to give them the independence to be able to manage their own appointments themselves, even if they need support from the family and the carer. So there are some dementia engaging and empowering people, I think is the deep, it's something like that. These groups have been set up across the UK, and they've been fantastic, and produced some great guidance on writing information and what they need to see, and the do's and don'ts. So this can be found on the Dementia Voices website, so that's really good. But also you need to sort of think about the clinical information that's going into the appointment letters. So it needs to be clearly written, it needs to be in a big enough font, but it needs to say the relevant things. So if somebody's receiving the letter, do they know what they're coming in for? So can it clearly state what they're coming in for, why they're coming in, where they're going, and potentially with a bit of a map, this is what you would expect at your appointment, who you're going to see, how long you're going to be there for, so people can get, they can know ahead of time what they're expecting, and they're not met with confusion when they get there. If this is in accessible format, people with dementia can read it, process it themselves. They've got the letter, they can go back to it. Family members can talk through it with people. So people with dementia have said that appointment letters are very, very useful and need to be adapted for clinical settings. Okay. The clinical environment, I'm not going to go too much on this because this is something that we have, there is extensive, you can Google dementia friendly environments, and also understand that, it's sometimes beyond your control to be able to completely redesign an outpatient clinic or a hospital wing or wherever people are working. But again, from these dementia groups, they've told us that environments are poorly designed for people with cognitive and perceptual difficulties, and they make accessing the clinics really, really hard. So if we're trying to kind of, if I kind of step back 10 steps now and say, we understand that there's this unmet need. We need to help people with dementia and hearing loss, but already we're producing barriers by, they're not understanding what appointment they're coming to, and actually the clinical environment's really challenging for them to come to. So I was lucky enough to visit the Dementia Academy at Stirling, which is fantastic, and they've done loads and loads of work, and they've got lots of things online. You can do some training courses, and that's all been designed with dementia-friendly design, and they talk in depth about signage. Signage and hospitals tend to be right at the top, and you've got to strain your neck. Some people with cognitive problems and mobility problems will find that hard. Signage needs to stand out compared to the walls. There's all these different things that are really quite simple and can help people to find their way. So we know that hospitals tend to be very confusing warrens of places, and if we're expecting people with dementia to come and visit our clinics, it needs to be easy. They need to see this way, this is the way out, this is the way to the toilet. They need to be able to see clearly where they can go, so that they're not met with confusion and panic, which can be a big problem for people in terms of orientation. Think about the layout of clinics, the layout of waiting areas. And this is, if we kind of go back to this FIPS principle of seeing your clinic and seeing your practice from somebody with dementia's point of view, and then visiting, is this going to be a challenge for people coming in? Are the hospital or the sort of the clinics tend to be very busy, they tend to be quite noisy, lots of people in waiting areas, there might be television screens, there might be lots of leaflets. They are quite busy areas in terms of sensory overload, and for somebody with dementia who really can't cope with this and also is struggling with their sensory loss, then the clinical environment can be really challenging. And by the time you get somebody into your clinic to really try and assess their hearing, you've sort of already lost them. They're already distressed. So is there something we can do there about improving the clinical environment and potentially offering quiet spaces for waiting areas, potentially offering which are quiet in terms of noise, but also quiet in terms of visual distractions and busyness, so people can just come along and really try and relax before their appointment. And I know this is something that Jack sort of pointed out as well when he was talking about doing the ASSRs, is we don't want to distress people before they've even started to do their assessment. So if we can try and minimize that as much as possible, that would be really beneficial. And again, this clinical environment, does it have to be done in the clinic? Could we do it in the person's home? And again, I know this is very different depending on different trusts, and people will have different views and whether they're allowed to do it. But this is something that might be helpful for somebody with dementia, because they're in their safe environment. They feel safe there. They're not confused. It's not busy. They've not had to wait, in a busy outpatient clinic for half an hour or however long, so that's something to consider as well. Okay, so when we turn to looking at actual audiological assessment, as I will sort of repeat, so I hope at sort of any technical specific questions, I'm probably not the best person to answer, but these are my audiology colleagues have helped with and have written sort of this, and when we've had a discussion about modifications. So early intervention is only going to be good when we're talking about people with cognitive impairment, and that's in terms of treatments for their own dementia symptoms and their own disease causing the dementia, but also any intervention you can give somebody with cognitive impairment as early as possible is only going to be good because of this progressive nature. of the dementia. You're going to have the best chance that they engage in the evaluations. You're also going to have the best chance that they engage in rehabilitation and they can get on with it well. But that's not to say that you can't just see anybody. And unfortunately, we know that that's not always possible. People with dementia tend to be diagnosed with hearing loss late. So what can we do then? One thing from talking to groups of people with hearing loss and dementia and their carers is encouraging caregivers to attend all of the appointments. They can be really, really helpful in guiding what the issues are and what people want to get out of it. And this is especially for people who aren't potentially very early on in their cognitive dementia journey. So they can be really, really helpful. But again, being mindful, you know, your patient is the person with dementia, but you will see, and particularly potentially people with you know, Alzheimer's disease and the later stages of different types of dementia, they will actually look to their carer to answer the questions. So having a you know, discussion, the 3, 4 of you, whoever's in the room, and it being everybody has their say, I think is useful. And only trying to get information from the person with dementia is not going to be helpful. So we've got to be mindful that because they have a diagnosis of dementia or because there's some history of cognitive impairment doesn't mean that they can't answer themselves. But if you are struggling, caregivers are very, very useful, and they should always be encouraged to attend the appointments, not only to help you, but also to provide a calm, you know, a calming reassurance for the patient coming in. A recent systematic review showed that 56 to 59% of people living with dementia, and this was mild to severe dementia, could undertake pure tone audiometry. Now, the studies were quite small that they included, and there were some people who'd said that they had modified the assessments. So things that we could potentially do would be reduce the test duration. Do you need to get the full PTA? Because people will lose their focus and lose their attention. So can we reduce the test duration? Can we give frequent reminders of what's needed, frequent encouragement? Going back to, make sure that they can keep sight of family and carers. Do we need to do the standardized PTA? Could we use different tones, which might be a bit more engaging? Can we respond with verbal ways? And I think this is kind of going back to the discussion from the questions before, is actually people will, you know, what do we want to get out of the audiological assessment? What are the aims of it, and what do we need to be able to kind of the minimum thresholds we need to be able to decipher? And consider non-behavioural tests, so such as the ASSR. There was a study done by Bott, which was published earlier this year, which showed that when they took into account ASSR and CATE, I think it is, cortical automatic threshold estimation technologies, they saw that they were highly correlated to PTA for people with dementia, but also 87.5% of people with dementia had estimated hearing thresholds. So when we do consider these non-behavioural tests as well as PTA, we can increase the risk to increase the chance that 90% of people with dementia can have audiological assessment. They did, and this is something I'd be interested to kind of have a discussion with Jack and with everybody about, is the feasibility of doing these non-behavioural tests in the clinic. Obviously, they take a lot longer, and you know, are they feasible to do within the constraints of clinical practice? Very sort of quickly then, looking at hearing intervention. Unfortunately, as we've sort of said, the research base for hearing aids and the hearing intervention for people with dementia is quite limited. We know from various qualitative studies and from different studies that people with dementia might struggle to maintain or look after hearing aids on their own. So we might need to help engage carers and family members to do this. They might not be able to actually physically use the hearing aids themselves if they have spatial difficulties, actually being able to pick up the hearing aid and putting it in the ear themselves, that might be difficult. But even if we take into account these, and we can kind of eliminate this, and carers can help with these factors, the hearing aids can't actually eliminate the impact of the excessive cognitive demands on listening tasks. So we're simply increasing, the audibility of sound, and I'm sure it's much more complex than that. And I don't mean to dumb it down, but it's just trying to understand that this person has physical damage in their brain, and so they still have issues with memory load and being able to decipher between alternating talkers and contextual cues, which I don't think any hearing aid in the world can actually help somebody, point them to. If somebody says a word, what does that mean? And people with dementia don't just struggle with hearing it, they struggle with processing the sounds. And so there is a kind of a big body of work which has been done in America and in Canada, looking at alternative hearing management options for people with dementia. And this kind of are things that should be used in conjunction with carers and family members and therapists. And this kind of goes back to our other piece of work where we're looking at supporting people with dementia. And simply, providing hearing rehabilitation might not be enough. We might need to use it in conjunction with communication strategies and environmental strategies. So the kind of good deaf awareness, I guess, comes into this a lot. Face the person, speak clearly, stay on topic, but it's even more important for people with cognitive problems as well. And then obviously environmental strategies, and these are potentially things that we could help them, to get the best out of their hearing, the best out of their lives, by helping family members to understand as well. So that's sort of all. I was sort of whistle-stop tour through that today. So thank you very much for listening. I just wanted to sort of put on here the different authors who have contributed to all of this work as well. So I can stop talking for now. I don't know if it's better for me to stop sharing this.
Thank you very much, Jenna. That was really interesting. And I actually jotted down a couple of questions, and then you went on to answer them on the next slide every time. Thank you very much. We were going to ask a poll before your presentation, but it's actually probably quite good to do it now while people are reflecting on what you've said. So Victoria, if you can put up the poll to ask if people already adapt their clinic for patients who have dementia. Oh, perfect.
Sorry, I think I did actually run it earlier on. Sorry, I did it earlier on before Jenna was speaking. Sorry.
Oh, no, that's great. You're on the ball, Victoria. So Jenna, one of the questions that I did think of is it's really good that you've got the recommendations on the way, hopefully this year, fingers crossed. Whereabouts in the patient's pathway do you envisage the hearing assessments?
Sorry, so do you mean the patient with cognitive impairment pathway?
Yeah. What point on that pathway?
So unfortunately, the guidance that we have, I mean, the specific for audiologists isn't going to say, you need to go and stand outside the memory clinics and bring people in. But this was the sort of the point of the international guidance, was to say it's not enough to, audiologists to modify their practice if people with dementia aren't coming into them. So we need to raise the awareness of the general public, and we need to raise the awareness of the clinicians working across the three fields, so that people, when they're going for, they're going to their GP, for example, and they're saying, we think we've got cognitive problems. Can the GP then say, right, I'm going to do a quick hearing and vision screen. Do you know it's very important? And start the conversation right at the beginning. If it's not picked up then, we've got recommendations that the memory clinics should say, I'm going to measure your hearing and vision, and there should be referral pathways in place. So these are the kind of the recommendations we've got for increasing awareness and increasing the recognition of the accounts. But that's not to say that somebody at any form of, any stage of their dementia should be able to have their hearing assessed and measured. But as I mentioned, the earlier the better would really be helpful, for everybody involved.
We had a couple of questions earlier on. One of them was, what's your feeling of the growing view that dementia is giving increased hearing loss rather than the other way around?
Yes, so I mean, this is potentially, in my view, dementia is giving hearing loss is giving dementia. We don't know, so we don't know whether what is this causal, why are they linked? And it could be, and this is something that I sort of looked at in my PhD, and I am really interested in, is it really the fact that hearing loss is increasing the risk of dementia, or are people with dementia who they have this disease in their brain which causes widespread neurodegeneration, and they have, and if we take Alzheimer's disease, for example, that's present in the brain 20 years before they have any clinical symptoms. So if we're measuring hearing loss at time 0 and 10 years later they develop dementia, the clinical symptoms of Alzheimer's disease, they already had that disease 10 years before they developed hearing loss. So it could, how is it that the hearing loss isn't necessarily increasing the risk of Alzheimer's disease? Is it that something is happening during the dementia process, which means that people's hearing loss shows up quicker? So I'm completely with you that saying hearing loss causes dementia, we haven't got the evidence for that, nor have we got the evidence that dementia causes hearing loss, but it's very likely that there's an interplay between neurodegenerative processes.